Ladies and gentlemen, allow me interest you in my proposed research topic, peer communication, cognition, and health, male health-seeking behavior. A case study of men seeking BMMC in Kampala and Wakiso. Um, well, in a nutshell, what is known about this topic is that clearly men have been stereotyped to uh, have a delay when it comes to seeking help when they are ill or seeking health services, health interventions in comparison to women. And this has been seen in many societies of different calibers. And the goal now is for this particular research, is to establish if there is a correlation between male peer communication, male peer communication, and when they choose to, when they choose to seek help. What is interesting is that this has been also um, associated with culture perceptions and masculinity in different parts of the world, and and this causes more need to look into it and see what this phenomena is about. Um, the benefactor, basically, men health-seeking behavior is a broad phenomena, and contributing to the effort in filling this gap is basically relevant, especially to behavior change communication stakeholders who seek to innovate in that area, and it is very relevant because once there's a way to interest male into participating in health, health innovations and to improve this poor health-seeking behavior, it is not going to be beneficial for only the men, but also the women and children that they share societies with. Yes, so the aim of the study is to establish the correlation between adult male communication, peer communication, and their cognition process on when to seek health services. I am proposing for objectives that feed into each other, and these include to quantify the average delay associated with adult male seeking health services, to establish the role of adult male peer communication in their decision to seek health services, and then to generate common experiences, thoughts, and sensations associated with decision to seek health services among men. This particular objective is geared towards appreciating the cognition process. That's why I'm looking at thoughts and sensations, and then experiences, to try and appreciate the process that might be leading to the cognition on when to seek medical services. And then the fourth objective is basically to establish the correlation between the found experiences, thoughts, and sensations, and also that probably the delay that would be established in that is average delay, as when the men take to seek health services. Well, the research questions are directly from the objectives, and basically we want to find the average delay associated with adults to seeking health services, the adult male, and then we also want to to find out the role of peer-to-peer communication in their individual decisions to seek health services, and then also maybe try and see if we can highlight the experiences, the thoughts, and sensations associated with the decision to seek health services among the adult men. And then, of course, what is the correlation between men's experiences, thoughts, and sensations and their delay to seeking health services. Literature review is still work in progress, and but however, we've been able to find some some idea, some theories and some research that suggests that there is actually a delay that has been, the trends have been seen, for men waiting till it's too late either to seek medical services or or probably just don't go. And there's a citing there from the Populational Census Office in the UK that suggests, less than half of the men that were, we have about 143 million women going for health services in a given period, and then only 67 million men in the same period, which is less than half when you compare the two. And these are all exposed to the same dangers and the same needs for health, but there's significant difference. And the research acknowledges the established poor health seeking services in men, but and then we know that there's a hesitancy. So this is part of why there's the inadequacy that has been highlighted by other researchers in explaining their process involved in men seeking help when they need it. Is where we want to get our interest in. And social cognitive theory describes three modes, and it says that that we have the mode, both personal, proxy, and collective, and all these work together to influence an individual's decision, towards a desired towards reaching their desired goal and or output. And that personal is basically how the person influences themselves by simply self-motivation. But then proxy is the motivation that is pushed by seeing others or seeing someone else, either do something else or inspiration kind of. And then collective is when now it is a group effort. You're geared towards the same goal and you're working together towards the goal. This particular study is focusing on the proxy and the collective, where we are looking at how the rest can influence an individual towards the tipping point of taking a decision to seek health services. And this is where we're coming from. So we're trying to see if we can establish, the type of correlation between cognition and the delays in health services. We want to know, is there a correlation at all? If it's there, is it positive or negative? So that we can see how we can manipulate that to be able to improve this behavior among male individuals. Peer-to-peer communication, basically, which is the other variable in this study, proposed variable, is basically conversation, communication between friends, between people who are considered equals. The conversation is in such a way that any one of the parties can start the conversation or end it, and no one is in that conversation because of obligation. It is because of liking. And this is why we imagine that the decisions that come of these kind of conversations, could go a long way into helping people take decisions, because they are not forced into these kind of conversations. And that's why peer-to-peer communication is co-interaction is an area that could be of interest to see how best it can help in helping those that have challenges, especially men, those that have challenges in this scenario, in accepting health services or interventions, accept them. This is a table basically to try and summarize the research design. The research type, this will be a non-experimental quantitative type of research, and the data collection will generally be done by interviews and focused group discussions. The research will have a descriptive correlation design, because we intend to, describe the variables and the relationships that happen between them naturally without interfering with them. And And then the population ensemble, we were looking at men aged 18 years and above recorded to seek medical male circumcision voluntarily at selected facilities between October 2021 and December 2021. The scope will target 7 designated public health facilities and that provide free VMMC in Kampala and Wakiso districts. The reason why we are focusing on these public facilities is because they offer free service, and then also the fact that we do not want to have the issue of maybe affordability being a huge hindrance as to why men are maybe delaying, or so we want to assume everyone who has come in there did not have a challenge of maybe monetary challenges and things like that. So to increase the chances of these men understanding the cognition and things to do with the decision making, basically. So the sample selection will be stratified random sampling, and we're choosing stratified because we want to be able to have representation from the different age groups. And good enough, this is a male service, so we're not going to have females coming for BMMC, but we would want to have men at different levels, men at different age groups represented, so that we have a clearer, bigger picture, better representation. The research, the sample size will be determined by the Chrissy and Morgan table. That this is what we propose to use. The research methods basically will be the data tool collection. The tools for data collection will be questionnaires and guided interviews, and then analysis will be done by statistical analysis methods, because these are the best fit to test relationship among variables. So practicabilities to collect this data, a period of say 3 months will be sufficient, and all VMMC services have mandatory follow-up durations. So we intend they usually have these contacts, so we intend to use the contacts to retrospectively find these respondents, reach out to them, and then be able to interview them and interact with them. And for those that will refuse to participate or that are not accessible, we will replace that sample with another individual from the same data set, to ensure that we have the actual sample set, the sample size that is required. And and that's basically the major challenge that we expect is probably not to have to have some people reject to participate, but this we can continue by reassuring them reassuring them, of course, for confidentiality, and helping them appreciate the purpose of this particular research. Well, the implication and contribution to knowledge, this research definitely will be relevant to the field of behavior change communication, and among others, and a meaningful understanding of these relationships can be exploited to improve advocacy for efforts to improve male health seeking behavior, and which can, of course, result into improved quality of life, not only for the men themselves, but like I said, the women and children in their societies where they live. These are the references that I've used to come up with this proposal, and I thank you for listening. Thank you.